is confidential. It may be seen. So welcome to the Health and Wellbeing Board for Thursday the 9th of January 2025. We do have some apologies, so from the Chair, obviously, because I'm Vice Chair and standing in today, so from Paul, Councillor Mark Purvis, Councillor Guy Renner-Thompson, Sharon Williams. Now, we did have a substitute for Sharon called Kim Whitehouse for the LPC, but sadly she's just had a phone call and had to leave. But there is an amendment in the minutes of the last meeting, which I'll come to in a minute, that she's asked us to raise. Russell Nightingale, Victoria McFarlane Reid. Anybody else? That's it? Right, okay. And as with tradition, we'll just go round and introduce ourselves, if that's okay. So I'm Graham Sayers. I'm a clinical lead at the Integrated Care Board for the North East North Cumbria, and I'm a GP in Alnwick.
Morning, everyone. Happy New Year. Jill O'Neill, Executive Director, Public Health, Communities and Inequalities.
Veronica Jones, County Councillor, Cabinet Member for Improving Public Health and Tackling Inequalities.
Alistair Brown, Executive Medical Director at Northumbria Healthcare.
Hilary Porteous, Executive Officer, Local Medical Committee.
Morning, everyone. My name is Jeff Watson. I am the Cabinet Member for Healthy Lives, and I'm also the County Councillor for Amble West with Warkworth.
Morning, everyone. I'm Chloe Mann. I'm a Police Director for CNTW.
Yeah, good morning. I'm Kevin Warren, Police Superintendent for Northumberland.
Morning everyone, Ashley Eyston, Head of Public Health Nursing for Harrogate and District Foundation.
Hello all, Neil Bradley, Executive Director for Adult Services at the Council.
Good morning, Peter Stanfield, Chair of Health Watch Northumberland.
Morning, Vicky McLeod, Director for Children, Young People and Families.
Morning, Abby Conway, Chief Executive Citizens Advisor representing the voluntary sector through Thriving Together.
Hi, Jim Brown, Deputy Director of Public Health. I have a couple of reports on the agenda today.
Wendy Patterson, County Councillor for the Long Houghton Division and also Portfolio Holder for Caring for Adults.
Andrea Todd, Democratic Services.
Thank you. So next on the agenda is to agree the minutes of the meeting of the 14th of November. So firstly, does anybody wish to raise any items from the floor at the minute? No? So Jim, you're looking as though you do, or you're not? No? Okay. So we have one correction, which was from page 6 of the minutes, and it was the bullet point second from the bottom regarding the North of Tyne LPC, and Andrea's got the correction.
Just so it reads, the North of Tyne LPC had met yesterday, and at this meeting the PNA risk assessment was discussed and the committee felt it wasn't appropriate to publish due to potential risks to contracts, full stop. Then pharmacy was a depleting market and without adequate funding would further suffer, full stop.
Thank you.
You happy with that amendment?
Is everyone happy with that amendment? Lovely, thank you very much. Item 3, disclosure of members' interest. Does anybody wish to declare an interest at this point? No, thank you. So that brings us to the first main agenda item, which is item 4, demographic impacts, and that's Dr. Alistair Blair from Northumbria Healthcare Trust, and he's got a PowerPoint presentation for us.
Thanks, Chair. This is really, I suppose, just I hope, a glance into the future based on the evidence of where we are today, that I think is a kind of rallying call about how we collectively need to think differently about how we are going to look after the health of our population. So we all know, A, that there is new house building in Northumberland, and this isn't talking about anything with regards to people arriving in new homes. This is looking at the ONS figures on the current population of Northumberland, which are quite accurate. They can predict forward, given we've got a relatively stable population, how that population will change over the next few years. And it is an ageing population. So if I look at this, and this slide I hope explains what we're trying to show, is if you imagine somebody who's 85 who comes into hospital spends more time in hospital with the same problem than somebody who's 65. They've got more needs, they're more complex, they take longer. And this is really looking at the bed occupancy over every sort of 5 years based on what we're currently doing. So we've looked at every age group, every admission over a period of time for a 12-month period, and then rolled it forward. If we did exactly the same as we're doing today with the future age population in Northumberland, what happens? And you can see that the need for hospital beds goes up fairly linearly over the next few years. But it's quite scary. If you think we will need an extra 242 beds by 2040, that's the same as NSEC in terms of a whole new hospital. And that's simply to cope with, as we're doing today, the care that we're given today, and we know that we're some of the most efficient care in the country, with the changes in the demographics. If we add in a change in the population as it increases with new homes, that will increase that further, and it's quite dramatic when you look at that. If you then look at the next slide, this shows that the majority of this is in our over 75 population. So this is not a lot of people of a younger age group coming into hospital and needing beds. It's going to be predominantly those over 75. They will also, I suspect, interface with social care. There will be bits around residential care, nursing care as well, and how we look at that population as a community in Northumberland is going to be important. I would say these figures are both for Northumberland and North Tyneside, so that from a hospital perspective rather than purely from a local authority perspective, but the message is fairly similar, and if anything it's slightly more acute based in Northumberland than North Tyneside, but the pattern is there, and I can break it down by local authority, but this is more about a theme rather than being specific. So we could see specifically those, and of those two, you know, of the beds that are there for the totality, the vast majority of those are over 75. If we then, that's a total of 229 of those beds are for those over 75, high risk of falling, needing much more care within hospital because they're frail, complex, etc. And if I then look at what this means, if we translate this to what currently happens at each of our sites, you can see that's effectively a new ward at Hexham, several new wards at NSEC, at North Tyneside, at Wansbeck, as well as some bits at our community hospitals. But the most of that is going to be focused on the main sites at Wansbeck, Cramlington, and North Tyneside. If we then look at patients coming through to emergency department through acute presentations, that does go up, but it doesn't go up by nearly the same amount. It's up about 50 a day. We created an emergency department that was based on about an average of 250 attendants, so that goes up by quite a significant percentage. But I think that's capable with. The difficulty is that that will then be a very different skill mix, because again, the predominance of those are going to be more elderly, and therefore will have slightly different needs. most of those are going to be going through to Cramlington rather than going to the urgent treatment centres. If you look at the kind of patterns that are there, and that significantly is 40% an increase in the over 75s in particular going through as an emergency to Cramlington, and that will have implications for ambulance service colleagues as well. This is not come with an answer other than saying we aren't going to build another hospital. There is no funding for that. There is no planning for that. We all know in this room how long it took to build NSEC. That was a very long incubation that had started probably 10 to 15 years before the building was built. We're not proposing that, but we are thinking that as an economy, we're going to have to look very differently at how we cope with the changing demands of our demographic population, and that will be different from the rest of England. So we are going to be atypical in that. Not everybody's experiencing those same rises in the same way. But the reason I thought this was a good place to come is it is really a good way to look at the impact of what is very robust public health ONS data that actually interfaces with, you know, social care, ambulance, with all bits. And I think if we then look at, you know, a number of those are going to be under CNTW with dementia, there's going to be a whole set of security for each of the health providers in the room. And I think for us as residents in Northumberland, you want to know that when you're there, there's a bed for you when you've got that need. And most of us in this room are getting older, so it has more of an impact for all of us. So it's quite eye-watering. And 2040 sounds like it's a long time away. It isn't, and if you look at those gradual increases, it's not a cliff edge, it's a gradual mounting of pressure over the time. So it was really just to raise it because I thought it was useful to share, but it is our collective problem, and we could use the same figures, I suspect, for most other indexes of how we deliver care. Will have implications for primary care too. So it was more as a discussion point than anything.
Thanks, Alistair. And it's also, if we listen to everything in the news at the minute, is about our overcrowded hospitals, which is about flow, is what, you know, we hear about the accident and emergency departments, but actually it's largely a lot of older people with more complex problems who need to be in hospital longer than the average, and if you magnify all of that forwards, it's not an easy situation. I'd welcome comments from the floor. Jeff?
I think that was a wonderful presentation that really put it into perspective, the whole thing. But I'm really surprised that we're sort of just thinking about that now, because after the Second World War, everybody knows there was a huge baby boomer, and you know, I'm one of them. And I'm already several years older than my mother and father were when they died. So it's not something that should have come out suddenly and bit us in the bum. It's been around for a long time. We've known that older people are going to be older, and we know older people have more complex needs. I'm just surprised that we're just kind of trying to grasp the nettle now.
I'm not sure that we're just trying to cross the nettle now. I think the demographics in Northumberland are very different from the national picture as well. So I think we need to be aware that this, if I could go for the same figures in other parts of the country, and there's negligible change. So this is a Northumberland issue rather than a national baby boomer issue, though we have got a slightly ageing population across the whole of England. But we've known about this. This is just another way of presenting the data. But you're right, but it isn't new. But I think viewing it in terms of this way is just another way of rallying around the issue.
I mean, I'm a great supporter of Northumberland Health in generally. I think we do a really excellent job, and figures show we're one of the best in the country. But you're right in that we've been fairly stable, I think. I mean, and all the time I've been a councillor, the population of Northumberland has hardly moved. So we've been known about this for 25 years. And I just think it's, you know, just a shame we couldn't have actually reacted a bit before now. Anyway, that's water under the bridge, I suppose, but yeah.
Thanks. Abby?
Thanks, Alistair. A really, really great presentation, and I think what it did for me was really solidify the place that that Northumbria Healthcare has within the whole prevention agenda that very much forms the part of this board and everything that we're doing around sort of as a system, because it's really going to be incumbent to do something different. And it starts to have that conversation about, it almost forces change, doesn't it? It forces that kind of culture change. You know, COVID did that. COVID forced some culture changes, that some things, you know, working remotely and doing things more. I think that the way you've presented those figures, really, we should be then reflecting and thinking how we can't continue to use healthcare as we have always done, because it just isn't going to work. So I think it's really powerful to be able to then start and kind of include that in those wider conversations that we've been having with Jill and colleagues and stuff around that prevention agenda.
Yeah, I think the key is that people will still need to use healthcare, but not in the way that they're currently doing. So if we look at virtual wards, if we look at lots of the other ways, so this shouldn't be about denying access, but this should be about providing different ways of caring that are equally effective, but just not all going to be in a hospital bed.
Thanks, Alistair. I think for me what this highlights is if we don't change, that will be the outcome. But everything that we have got in place through the county partnership, the work that we're doing with the Institute of Health Equity and such like, all the development sessions we're doing, we know that the structural changes around housing, employment are the keys beyond just individual behaviour change. So you recall from the workshops we've been having, 20% of health outcomes are attributed to good homes, 35% are attributable to material deprivation, poverty, good jobs. We've set ourselves at 2044, change a generation. That is the 20-year trajectory. So if we do those things, we can affect what Alistair is presenting to us. So I think as much as anything, for me, it's a call to action and a reality check. What we're doing are the right things, but they will take time to implement, whilst we will always need good quality health care. But hopefully that independence in the home piece is where we can all work together.
It was just to come back on because I think presenting that data in such a way is really excellent. And actually, to Jill's point, almost we can hold ourselves to account using that data, and that's the way to demonstrate that there's been an impact and effect. Because we all know what we're working for, but actually being able to check and hold that to account, I think is brilliant.
I think that's a very useful presentation, and I think for the rest of us, it would also be useful to map that impact out, because that's the impact on secondary care, but what's the impact on primary care, community services, social services? Because I think that would be very powerful to see what's the impact on the whole system, not just one part of it.
Yeah, I mean, just to echo, I mean, Alistair, we face very similar pressures within adult social care. I mean, I know yours manifests itself in terms of beds. Ours manifests itself in terms of workforce and budgetary pressure generally. I mean, I think a lot of the forums are now in place for us to start to talk these issues through, and Jill, you've just referenced a few of them. I think very much what I'm pushing with my teams is we need to be coming in and taking quite a technical view of the discussions in there and what can support adult social care. And I think as well from a medical and clinical perspective, having full input to see, you know, when we're talking about housing options, housing delivery, use of DFG grant and things like that, what will maximise the benefit from the medical side of things, from the hospital bed side of things, from the policing side of things, from the social care side of things, etc. I think we're moving soon, I think, into that next granular level of detail. And I think it's really important we're all brought into those forums and coming, not just to talk at a high blue sky level, but I think we need to get into some of the detail now and work out what, in reality, NUB actions and how we direct resources is going to really deliver some outcomes for it. But I think the forums are there. We've just got to use them effectively now.
Thank you. We'll close that bit of the agenda down, but it segues very nicely into the next bit, which is actually how we work as a system, and some assurance from Jim on the next agenda item in terms of what we are doing. What I was going to ask Alistair, those slides are just embedded in the agenda pack. I think it might be really useful to have just the ability to use that top slide of yours in any of our forums to say, here's a bit of a sound bite, and we'll take that to the System Transformation Board as well, I think, and just highlight that. Okay, thank you. So, moving on to items 5 and 5.1, the report on the Joint Health and Wellbeing Strategy theme, adopting a whole system approach to healthcare. And I think, Veronica, would you wish to introduce this?
Yes, I'd just like to say a few words, if that's okay. A whole system approach to healthcare is basically how we work together, and it's part of our health and wellbeing strategy. We refreshed the strategy for 2020-28, and that came to the board last October. We did have a report then on the achievements and how the proposed amendments and priorities. So subsequently in May, the whole strategy was refreshed. So this report now that Jim's going to provides an update on the progress made by the Council and our healthcare partners against the proposed amendments to priorities, the key achievements, actions for the future and the opportunities for development. Dr. Jim Brown will explain that far better than I can, so I'm just going to hand it straight over to him to present the report. Thanks, Jim.
Thank you, Councillor Jones, and thank you everyone for this opportunity. As I said, I'm Dr. Jim Brown, Deputy Director of Public Health. It's a bit of the Jim Brown show today, a couple of reports, so I'll try to keep it reasonably brief if I can. What I'm not going to do is parrot both reports. I'm going to assume you've had that opportunity to read them, but maybe just sort of give a little bit of kind of update and a little bit of a summary of what you're going to see. As Veronica has said, the purpose is to provide an update, and it's really just about this is the progress of system partners. Many of you around the room, I'm pleased to say, are part of System Transformation Board who are asked to update about achievements, and that's why we've been monitoring progress for this theme. So I'm not going to be the expert on everything. I'll do my very best to answer any questions, and maybe others in the room who can assist with that. But actually it's to recognise the huge amount of work. And if the agenda pack looks a bit long, it's partly because I have included the appendix, which includes actually the huge amount of work that's ongoing, just to demonstrate that whole system approach. And I guess it's also saying that it's with that lens of a whole system approach I've kind of assessed actually our progress. Just by means of recap, and thank you, Veronica, just for introducing that this is by way of an update of the strategy. There are now 3 kind of core themes to the Joint Health and Wellbeing Strategy: starting growing up well, building blocks of good health, which you'll hear about through this year, we'll be feeding back, and then adopting a whole system approach to health and care, an overarching theme now of empowering people and communities, and those ongoing cross-cutting themes that you can see there, and the methods of demonstrating progress of the overall strategy around self-reported wellbeing, and looking at the inequalities in life expectancy. And I think crucially, from the conversation we've had today about healthy life expectancy, putting life to years, which is actually crucial in reducing inequalities, that's actually the crucial thing about if we're going to address the issues that Alistair has just talked about today. I'm not going to cover those today because I think it's too early, so we don't have up-to-date data to demonstrate the impact of this first year, but I think that's something we definitely need to hold us to account to be coming back to in future years. So we had a refresh of this theme. The outcome was unchanged, but the 3 priority areas were slightly amended. Not the first. We still need to focus and prioritise prevention and health promotion, as we've talked about today. We've slightly amended to priority 2 to drive integrated, coordinated, personalised care, and crucially user and carer and patient and resident involvement in the health and care system. So not just about healthcare, but health and care systems. So it includes social care. And that third around some of those inequalities in particularly secondary care in terms of elective activity, but actually others around the system. So looking at screening, vaccination as well. So kind of, I suppose the question is, well, why a whole system approach? And what do we mean by that? It's really just understanding about how the different, it's more complex than that, but it's understanding how all the different parts of the system work, and actually a recognition that, as we've seen today, coming together and collaborating, forming partnerships is actually how we can amplify the work that we do. It means building those and maintaining the relationships, the trust between people, between communities and organisations, I think crucially as well, but also having that kind of shared meaning, that shared purpose that we need in order to kind of move forward. And I think, just as we've seen this morning, just understanding what the future looks like is one of those mechanisms. So as I say, when writing that, it's with this lens that I've kind of hopefully concluded what I think are the opportunities that we need to think about in the coming year. So I'm not going to go into any detail in this, but these are the actions that we committed to in the refreshed Joint Health and Wellbeing Strategy around Priority 1, around making every contact count, some of the big ticket public health issues and mental health, and some of the there's early identification and management of the risk factors for cardiovascular disease, which is one that still remains one of the biggest impacts on health inequalities. There's also, for groups, people with severe mental illness or learning disability who have worse life expectancy than the rest of the population. So one of addressing some of those inequalities partly through some of the annual physical health checks, because you know that physical health is a major issue for people in those two groups. And then maximising our corporate social responsibilities, anchor organisations, which many of us are part of here today. And then finally, just the other two priorities are Priority 2, focusing on integrated neighbourhood teams, which we'll come on to, system-wide intelligence strategy, the joint strategic needs and assets assessment using population health management approaches, and then, as I say, some of that involvement in decisions, both about commissioning, planning, delivery, but also for individuals in decisions about their own care. And then finally, as we say, a focus on some of those healthcare inequalities, both in elective care and elective activity, but also in terms of screening and vaccination, and trying to just make health equity audit just kind of business as usual, really. So I'm not going to talk about everything that's in the report. I'm hoping even the report in itself is actually a summary of just some of the highlights that I've just tried to kind of collect of the huge amount of work that's ongoing. Smoking prevalence is probably one of the most important. You're going to hear about that from Kerry later on in terms of that's fallen to its lowest ever of 8.2%. With the drug strategy money contributing to the work that we do using public health grant around drugs and alcohol, but also the drugs and alcohol service. We're seeing drug-related deaths decreasing, which is fantastic news because we have in the past been higher than the rest of the country, so that's fantastic. We've seen the development of new sexual health strategy that was presented recently at Health and Wellbeing Board. We've seen with COVID, we saw a big drop in NHS health checks, which are there to identify risk factors for cardiovascular disease, particularly premature, early. We've seen uptake come up, still variation, but it's come up to levels that we had pre-COVID, and it's taken a lot of work to do that. Crucially, we've seen an incredible improvement in the percentage of people with severe mental illness having annual physical health checks in 2023-24, and actually well above the England average. Some great examples of the work that we're doing as anchor organisations. Just an example of the Northumberland line demonstrating 16 million in social value, which is incredible. And all of our organisations are working really hard to demonstrate actually how they're adding value to the lives of people within our communities. Some really good examples of patient service user care, resident involvement, and some really nice examples within organisations, both of Northumbria and Cumbria, Northumberland, Tyne and Wear trusts of the work around health and healthcare inequalities. And actually a really nice example is how they've come together with respiratory in-reach clinics in the Drug and Alcohol Service, Northumberland Recovery Project. I'm just going to go into really, really briefly because I think it's a really lovely example of actually how we've worked together. So this was using funding from the ICB Health Inequalities Fund, which Public Health and Local Authority were asked to allocate. And we just had the final report on the final evaluation. Over the past 12 to 18 months, 25 clinics, we've seen 134 new patients. Now, this is a group of people who have really low life expectancy, and that's not just about about drug and alcohol use. It's actually a lot of it to do with the smoking addiction, and actually that's not only what causes death in terms of COPD and lung cancer and others, but also in terms of actually making people more likely to die during overdose as well. And we know that there's a huge unmet need, and that was really shown, and that actually 96% of people require treatment for many people who are new diagnoses. And this, we knew this before, but it was reinforced in the evaluation that this was they face a lot of barriers to accessing treatment in terms of stigma, in terms of low confidence, in going to the doctor, in terms of not necessarily seeing that as a priority, low health literacy as well, and low literacy as well as that. So service users really identified they felt valued, they felt listened to, and really valued the kind of flexibility and the adaptability of clinic staff. So I think a huge credit actually not only to the respiratory staff that went in, but also to the staff at Northumberland Recovery Project and the peer workers and the physical health nurses who had to work actually to get people in. So it's the system working really nicely together. Now, actually, crucially, I think this is another important part. For being able to evaluate for the first few months, actually demonstrated a halving in the number of people, in the annual number of attendances in emergency care and in hospital. So actually, for an investment here, we haven't looked at exactly what the modelling of, the cost effectiveness, but actually to demonstrate by this proactive approach, we're not only improving the quality of life, improving the health, but actually reducing admissions to hospital. So in terms of what we've just talked about, this method of addressing inequalities is really important and addresses some of the healthcare utilisation issues as well. It's not all rosy, and it's really important to celebrate achievements, but we still have a lot of challenges. I think it's post-COVID. We saw an increase for certain groups in terms of alcohol use and alcohol intake, and I've seen an increase in alcohol-specific deaths, so deaths solely due to alcohol in the years following COVID. We're just beginning to see that beginning to come down, and hope that is a trend that is coming down. Also see hospitalisations increase, and so there's an alcohol strategy in development, which hopefully will be presented later this year to have a wellbeing board. But I think that's actually a vital part of how we work as an entire system to address alcohol, and think about how we influence obviously policy at a national and local level as well. And also we continue to have a higher than England average of suicide rate, and that's prompted a refresh of the suicide prevention strategy that it will also be undertaking this year. So absolutely crucial issues that we need to address locally. There's a huge amount of work through community transformation, through suicide prevention already ongoing, a lot of commissioned service to support bereavement support, but it's prompted that refresh as well. And some of those plans, strategies in the year ahead, there's an awful lot of work ongoing around alcohol prevention, strategies and development. As I said, suicide prevention, adult mental health is planned, a plan around CVD prevention or implementing the ICB plan, a refresh of the physical activity strategy, a refresh of the plan around physical health in CNTW, and work around improving equity of access for children and young people in CNTW, work around screening inequalities, and also a planned system-wide intelligence strategy. As part of the integrated neighbourhood working and team funding, Northumberland PCN's embarking on a project to improve management of diabetes in housebound patients. And many of you will be aware of, as part of the inequalities plan, been using the Place Standard tool, and that's being rolled out, to engage communities in a more detailed and kind of structured kind of conversation, just to do it in a consistent way. And with some of that other funding from the ICB Health Inequalities Fund, there's a Healthcare Navigator post been recruited into housing, which is quite innovative, and also within Northumbria, really to help some of those people, as we've talked about already, who have multiple and complex needs to access the care that they need and to do that appropriately as well. So I think there are a number of opportunities that I've really just tried to kind of summarise when, kind of surveyed across all of the work that we're doing. We're all doing actually an amazing amount of work ongoing, but we are still to some extent within some of our silos, and I think there are opportunities for us all to collaborate more around illness prevention, around reducing healthcare inequalities, and around, I think, some of the intelligence. And I think we've seen that example today, if we can think about actually, not just secondary care, but primary care and adult social care, about those kind of projected needs into the future. So I think there's that opportunity for us to, to further collaborate there. Integrated neighbourhood teams is a core sort of policy, nationally, locally in the ICB. I still think that's in its early stages, and really I think the challenge here is to make it relevant to partners outside of general practice and primary care networks, and there's a workshop next month to focus and give a head of steam to that as well. I think some wonderful examples of involvement in kind of commissioning and planning and delivery, but I think we also need to just close the loop on that, and I think that's one of the areas that Health Watch is fantastic at, but just holding everyone to account, not only involving service users and carers and residents, but actually then what difference has it made, and actually we tend to find that it improves outcomes for people when you do that really, really well. But not only that, but also I think maybe what I'd probably take some of the responsibilities just to actually demonstrate that we also make sure that people are involved in decisions about their own care, and the personalised care agenda is foremost. So I think that'll be a focus over the next 12 months as well. And also finally, there's some good examples of health equity audit, whether in sexual health, around Stop Smoking Service, but actually just making that business as usual across everything that we do, and that's part of the inequalities plan as well that we're all signed up to. So I think moving forward, we have the System Transformation Board, or the Northumberland Subcommittee, place subcommittee of the ICB, is a place where this theme is monitored and where we're reporting into on that. So I think we've shared some of these opportunities, and we're going to work on that, I think, Graham as chair, over this next 12 months to think about how we can move forward some of those opportunities. I mentioned about that workshop led by the GP Collaborative with partners in Northumbria around integrated neighbourhood working. So bringing it down to some of those small place levels, 30 to 50,000. I think, I believe that Siobhan Brown, who you may well know, used to be Chief Operating Officer of the CCG, now heads up the Healthy and Fairer programme within the ICB, which is a particular focus on health inequalities, is offering to come to Health and Wellbeing Board. So I think when she does, it'd be great to take that opportunity. But it's about making sure that we're keeping those links in with our ICB and making sure we can think about how we do things at place level. And in discussions with Derry, Health Watch, and with Joe Wally, the ICB involvement lead, about just how we can keep those excellent case studies and examples of service user and resident care involvement, and just kind of get that feedback loop absolutely right. And this report was also going to go into the VCS liaison group as well. So I hope just holding us to account to just consider thinking about communities and VCS and the role as well, because I think STB is an area that's quite focused, I think, more onto the healthcare and social care, but it's actually thinking about the role that communities have and the communities first approach that we need to take. So our recommendations is the final slide, Graham, you'll be pleased to know. Health and Wellbeing's board is invited to note and comment on progress against the actions that were refreshed, and in particular comment is sought on the further potential and benefits of increased collaboration and integration between sectors and organisations, whether at place level, so I think Northumberland level, but also at neighbourhood level as well. So thank you for your time.
Thank you very much for keeping to time.
Welcome.
So we do have time for some comments and some discussion. It's really good to see that list of achievements, I think, because often what we tend to do when we're working in a system is talk to each other about what's not working so well. Now, I also know that in Northumberland, we actually have relationships where people are able to approach each other and talk about that. So we have good relationships, but I don't think we always necessarily focus on what's actually worked well. And having a report where it actually points out some of these things around how we are working as a system, I think is really valuable. So thank you. But can I please have some comments from the floor?
Sorry. Thank you very much. It's lovely to hear Jim. Because he used to give an awful lot of these talks during the COVID years. And it's really good to hear that, and for all the work that he's put in with others into this. I was expecting, when you touched on opportunities, to then have a slide about challenges. And so I would challenge you in the nicest way possible, just on the alcohol issue. And the figures for Northumberland are alarming, clearly. And it's not just hospital admissions, it's also the effect on crime and antisocial behaviour and so on. So my challenge is, what are we going to see different in the next 12 months in terms of trying to tackle this, or is it a problem that is untacklable?
I think a challenge is always an opportunity. So you're right to take me up on that. But because I think actually, it is important that we recognise that this is opportunities to do better, and actually that's and we accept that challenge. I think what will we see? I think it's really important with this strategy that it's consulting with system partners. So it's absolutely vital that it's not just a strategy that's written and expected everyone else to follow, but that people have that opportunity to participate, and that's the approach that's been taken. I think alcohol is achievable. I think the view certainly of Balance, which is the group that we fund in public health and all of the local authorities fund to assist with approaches with the general population around alcohol. The view is actually we've seen the progress around tobacco that you'll hear from Kerry, and actually whilst we're behind with alcohol, if we can influence national policy and align everything locally in terms of having we talked about Healthy and Fairer. They're helping to fund some of the alcohol care teams within Northumbria, so that means that everyone is not only asked about their alcohol use, but where they have high alcohol use, they have an intervention and are referred if they have issues that are likely to be around dependency. That we continue to fund our service, and we've increased people in the people with alcohol use disorders within the service by 20%, and that's partly through through additional funding that we're still seeing into next year. But it's also about the regular brief interventions that we have on, within general practice, but actually that everyone who is in frontline can have that opportunity to ask people about alcohol, get some of that stigma about, I shouldn't be asking about these things if I'm going to do a visit, whether I'm in the fire and rescue service doing safe and well visit, but actually to get over some of those issues, and also within sort of custody suites and that, to be having some of those conversations, not only about alcohol, but drugs as well. But it's also influencing, I think, the views of our, in our population, and that's where we have Balance to really help us in terms of really understanding what the views are in the population. And actually, as just an example around minimum unit pricing, where the evidence is certainly developed that it has an impact on some of the harms from alcohol, that actually broadly people are in favour of additional measures, and I think it's it sometimes feels difficult in the current to think that we can move forward, but generally when we have moved forward, for instance with the tobacco legislation, generally people have there have been worries that the public won't go with us, but they generally do, and particularly once they see some of those benefits in the population. In terms of whether on admissions or on some of those social issues that alcohol leads to, that I think we do see some of those benefits. Yeah.
Thank you very much for that. We did have quite a discussion at this council. Andrew will remember probably about 10 years ago about unit pricing and the benefits and the disbenefits. And I just feel it might be a subject that, because I don't want to hog the agenda now, but I'd love to know more about what are these hospitalizations, what does that look like, and what do you do about explain. I think the whole subject is very interesting, and it would be good perhaps to have a more of a session on this if we could at a future meeting.
When does the alcohol strategy work?
We're currently out for consultation on the alcohol prevention strategy at the minute, so that will be coming through into the summer, so we can have a dedicated or extended agenda item. Really welcome the challenge, Glenn. I think that's incredibly helpful as leader of the council to be particularly interested in this. We're probably about 20 years behind alcohol than we are from tobacco in relation to being really informed with industry tactics and how we look at that from a national perspective to what is in our gift of control at a local perspective as well. But with the continuation of funding, as Jim's highlighted, having the uncoupling, and CNTW have been instrumental, uncoupling drugs to alcohol is really important, because it's a very different cohort that we're working with, and seeing that 20% increase in people accessing treatment is really positive.
that people are coming forward knowing that they need help. So I think there's a huge amount we can do from a policy agenda perspective and revisiting that minimum unit pricing work, and we can bring balance into the conversation as well as our advocacy partner, as well as looking at the individual behaviour change work. So thank you, Glenn.
Thank you. I have Chloe and then Abby, and then I'll be looking to move us on, I think.
Mine was just to continue on the alcohol point. Obviously, CNTW have Northumberland Recovery Partnership, which is the specialist service for drug and alcohol, but anybody that comes into contact with any CNTW service out with Northumberland Recovery Partnership will be asked around alcohol. We complete an audit. We offer education, advice, and whether that be a referral into our services or into the services that Jim's mentioned. But I do wonder if we can learn from the positive story around the respiratory clinic work for NRP working closely with Northumbria Healthcare, and is there something we can do as system partners to really target that alcohol cohort? And I welcome the conversation that will be coming to the future board.
On the alcohol point, I agree with everything that Glenn said, but I think there's the wider part of the harms from alcohol. Yes, there's the individual health issues that causes for people, but there's the wider issue around domestic violence and things, and also in terms of long-term dementia from alcoholism. The point I was going to make just regarding, it was really positive to hear about the smoking and the hospital admissions for dental and the drug-related deaths, but the suicide rate really does worry me, particularly when it's so out with the England rate. And it was just an offer really from a voluntary sector perspective, because I know mental health is very important, but so are the practical issues and advice and support that exist around those the wider determinants of health, such as debt and why people possibly feel that there was a mental health issue and a mental illness issue, but there's also the wider issues around poverty. So it was an offer really from a voluntary sector perspective through Thriving Together to help to form that new strategy. I think it's very welcome. Thank you.
Some great work and encouraging lots of ways. I really welcome the idea about alcohol. We're already doing a bit of a pilot in Blythe because we know that's got a high level of alcohol use, looking at kind of proactive liver health clinics there. I think the other bit that's worth looking at the figures is people who are admitted with alcohol are not admitted because they're in addiction, they're admitted with a health problem, but also have alcoholism, so they need a detox while they're in, because they would withdraw, but they're not being admitted for their alcohol, they're being admitted for a medical reason, but also have alcohol as an issue. So it's worth looking at the context of those, because people wouldn't just go with alcohol to actually be admitted to hospital locally. And there is a whole bit, which I think that probably reinforces about the unintended consequences of addiction in its multiple forms in terms of utilisation of healthcare.
Sorry, Chair, for extending. It was just an additional thought, because we also play through drugs and alcohol into our strategic community safety partnership, and I'm just thinking, Kev, it might be actually added value to have a bit of a combined board conversation around the alcohol strategy, because John Liddell, our strategic specialist, has actually presented into the community safety partnership, because we know the crime and disorder aspect is incredibly important for us. So we'll take that offline and consider that.
Very quick one. Suicide rate is something that's bugged me for a while, and I haven't really gone into it in great extent, but I know it used to be people used to come in from North Tyneside and commit suicide in Northumberland, quite a few, because it was a good, quiet forestry place. I wonder if that's still the same. And I'm interested actually in the comment about, is poverty related to the suicide rate? Yes. Because actually I know unfortunately, I come across quite a few people who've been committed suicide, must be 4 or 5, and poverty was never one of the issues. I'm just wondering what the relative relationship is.
The national evidence, international evidence is that debt, relationship breakdown, mental health are obviously the larger impact. So yeah, absolutely, debt, money worries and relationship breakdown.
It's not sorry to answer you about Councillor Watson, it's people who are in debt, who are worried about money, and it's that worry that causes people to make that decision, because they feel their families are better off without them, and
right.
Yeah, it's
so I can relate debt
yes.
to death. It was the poverty I couldn't relate to death.
But there is issue around people, particularly young people. You know, Berwick's a perfect example of young people who feel that they don't have any future. And that is to do with socioeconomic circumstances, which can result in people taking their own lives as well.
Sorry for extending this further, just to say that obviously in terms of children's social care, alcohol, drug use, mental health is one of the top determinants that ultimately mean that children end up in our care because of those issues within families. You know, children go on to be adopted outside of the families because of those issues. So I'm really interested to be involved in the work around the alcohol strategy, how we can support that. Interested in hearing a bit more about the clinics in Blythe around the liver, etc., and how we can utilise maybe some of our family hubs to hold some of those clinics in and get that greater joint working. And then finally, just thinking about the suicide rates and some of the statistics, what we had, I would be interested in knowing how, as the northeast of England, I know we focus on Northumberland, but how as the northeast of England we stand? Because I know if we looked at children's social care, the northeast of England actually stands out on all of our data in terms of children who are in need, children on child protection plans. And if this is another area that the northeast stand out on, how can we actually, you know, have a joint voice back into government around some of these issues and rally a little bit more?
Thanks. It's linked to the suicide, and this is a very personal take. So 10 years ago, I was widowed by suicide, and since then I've become a very an advocate for suicide prevention. And one of the things is around language, and I think once the terminology, very common, everybody says commit suicide. Once you've been bereaved by suicide, that language changes, and the words commit suggests it's a negative, and it adds to the stigma. So I think we tend to say people took their own lives or people died by suicide rather than commit suicide. It just, I'm conscious that it can add to the stigma to those left behind as well. But before being bereaved by suicide, that was the term I always used.
Thank you very much for sharing that, and I'm sorry for your experience, Sylvie. Right, I shall sum us up. Firstly, thank you to all the leaders in the room and representatives and members of your organisations for actually enabling us to work as a system, because that's what's happening. So I think we are responsible for this, and we can take this away and we can make it work even better than it's currently working. So thank you for that. And then thank you to Jim for, on our behalf, telling us how we're doing, and actually also thinking carefully about how we can improve. And I know Jim and I do meet regularly to think about the interaction between the Health and Wellbeing Board and our System Transformation Board, the subcommittee of the ICB, but it is where we talk about how we do things differently and work together. And also with a view on the two main things that have been brought up today, which is our higher rates of suicide and the alcohol issues in Northumberland. So I think, thank you for comments, because that's been really useful, and we'll take that away. But can I just get you to agree that we agree to Jim's recommendations and taking this forward?
Would you mind very much if we just added to that, there will be a presentation report, full discussion about alcohol at the appropriate time?
Absolutely, we'll add it to the forward plan so that it's there, so we make sure we bring that back. Thank you. Okay, I'll move us on. The next item on the agenda is item 5.2. It's an annual report of the Health Protection Assurance and Development Partnership, and again it's Veronica to introduce.
Harm caused by communicable diseases and to minimise the health impacts of any environmental hazards. The County Council has a health protection duty which sits with the Director of Public Health, responsible for the Council's role in planning and responding to incidents which present any threats to the public's health. Having said that, health protection measures are undertaken by multi-agency partners and the Director of Public Health's role is to seek assurance that the arrangements are in place and we're able to respond. You may remember, those of you on the board then, that in January last year, Jim brought a report to the Health and Wellbeing Board on the proposed development of a Northumberland Health Protection, Assurance and Development Partnership. I have to say that carefully. It was agreed that the HPADP, would then produce an annual report to the board. So basically that's what this is, that this is the annual report following the setting up a year ago. So Jim's got a very full report of the setting it up and the work undertaken. We are, as a board, asked to acknowledge and comment on the multi-agency work of in providing assurance that appropriate arrangements are in place, and to identify and agree any developments that will strengthen that protection. So, Jim, over to you.
Thank you, Veronica. And just a point of correction, actually, who presented the report a year ago was John Lawler, who I'm delighted to say is back, who was a consultant public health with us and is now a consultant health protection at the health protection team at AXA and has joined us today, who was instrumental in setting up the board. Great, thank you for the slides. I appreciate it. There we go. You've done most of the first few slides for me, Veronica, so I appreciate that. In terms of what the purpose of today was. So I'll move quickly forward because I know Graham will want us to keep the show on the road in terms of really why we focus on health protection as one of the key domains of public health, and in terms of what we want to achieve. As I say, the background is that we do have a health protection duty, much as it's a multi-agency approach, and in terms of the management of incidents and outbreaks, it's often the health protection team, the UK Health Security Agency, who will lead initially. We have a role as system partners and also to be assured that arrangements are in place. So the Director of Public Health has a specific role in terms of seeking those assurances and that the arrangements are implemented and actually they're responsive to local health needs. So the board was set up in 2023, reported I think for to be formally reported back to this board about a year ago. So really, once again, as before, reporting on all actual amazing work that lots of partners have done. We were instrumental in that as well, but we lead the Health Protection, Assurance and Development Partnership, but it's actually the work that a lot of partners right across the system do. So I think it's another really good example of this whole system working. So the purposes of the Health Protection, Assurance Development Partnership are threefold. First of all, to support the Director of Public Health statutory role around health protection, ensuring that adequate arrangements are in place. The second, to act as a forum where partners use information to identify and agree developments to strengthen health protection response. And there's some examples that I'll give in a moment, but the particular focus on health inequalities. And then thirdly, to lead the local strategic response to a significant health protection incident. And one example would be a pandemic. So there's something about actually maintaining the relationship. So in the event of an incident that requires us to come together, we're not starting from scratch. As at times, we may have done that during, at the start of the pandemic. But actually, there's a good example of how we did that with when we saw measles cases increasing in the West Midlands over a year ago, and there was an MMR catch-up campaign. We came together in late winter, early spring 2024 with partners, just to make sure that we had all the arrangements in place. And I think that's, well, you always want to touch wood, but I think that's worked well for us because we haven't had any measles cases within Northumberland. So as I say, the partnership is broad within the council. It's public health, it's public protection, it's civil contingencies. So Darren Wilson, Helen Hines, who you'll know. It's AXA, so the health protection team are represented. NHS providers, so Northumbria. We have a representative from CNTW as well. from general practice. Appreciate your involvement as well, Hilary, and also from NHS commissioners, so both the ICB, local delivery team, and NHS England, who have responsibility for commissioning the screening and the vaccination programmes. We have focused on 6 kind of key themes in the past 12 months, and I think we'll continue to do that moving forward. Prevention and control of communicable diseases, health and social care associated infections in community settings, because we've not focused as much on hospital settings because there's very good governance within hospital trusts around some of the healthcare associated infections, around emergency preparedness, resilience and response, environmental hazards, immunisation, and then finally cancer and non-cancer screening. Now, that isn't always part of necessary part of health protection. It sometimes is, sometimes isn't, because that's more about early detection of disease and of having treatment approaches that you can bring that are more effective because because you catch a disease early. You know, whether cervical cancer, breast cancer, as examples. But there isn't another place where that's looked at, so we thought it was appropriate that it was within this partnership. So just to give a few, again, I'm not going to go into all the details. You have the paper to give a really a rich assessment of, I think, the progress we've made over the last 12 months. One of the key things is the development of a Northumberland and North Tyneside local immunisation steering group. And that came together actually in November this year. So there is a correction. It says 2023. One of the quirks of the system we use is that you can't make any changes for about a month before the meeting. So it is 2024 and not 2023. Prior to that, we had separate vaccine collaboratives that came together. So I think it's really important that this group meets. It helps to ensure that we're kind of matching the operation, the delivery, with the engagement approaches and brings partners together. It's only met on the one occasion, was planned to meet again today, but I don't know whether it was cancelled partly because I couldn't make it. But actually that's a place where we need to make sure that there is really effective governance and a really close look at how at the inequalities, say in particularly flu and COVID vaccination over the winter period, which we'll come on to, but also childhood vaccinations in pregnancy as well. One of the new things this year has been a new vaccination programme that started in the autumn around respiratory syncytial virus. You may or may not have come across that, RSV. It causes quite a large number, particularly of autumn and winter infections, particularly in young children and older people. So there's a vaccination programme for pregnant women after 28 weeks, and which is being led by the maternity services, along with all the other vaccinations, which we'll briefly talk about, but also in people 75 to 79 years. Now, in terms of maternity, actually, I think that's again been one of the really kind of great successes actually over this past 12 months. So there's a really extensive programme by our maternity services to offer COVID, to offer flu vaccination seasonally, but also crucially pertussis, whooping cough vaccines. And we've seen a big increase, which I'll come on to, in the number of pertussis cases over this past 12 months. And so that offer of pertussis vaccinations are really important. And then obviously more recently, the respiratory syncytial virus, RSV. But they don't just kind of, it's not a kind of a passive approach, it's quite proactive in terms of offering antenatal clinics, 20-week ultrasounds, daily drop-ins at outreach clinics and family hubs, and particularly in areas where we know there's lower uptake. They do weekly notifications, they do social media campaigns, individual counselling and promotion, and mass texting. So it's actually quite comprehensive, but it's still a real challenge in terms of maximising uptake. Northumbria had a crucial role during the pandemic around infection prevention and control. I think you'll be aware that was absolutely vital in terms of supporting the care homes and the wider care sector. And you may remember a bit over a year ago, we presented a community strategy around infection prevention control. And so we've seen the implementation of that with regular meetings over this past 12 months, led by our Northumbria infection prevention control team colleagues. But actually also involvement of education, of general practice, of our care sector, of our adult social commissioning colleagues, and actually we're already seeing, I think, some of those benefits, and it puts us in a really good position, you know, for ensuring that actually the training, the knowledge and the skills, that the champions are there to prepare ourselves for, I'm sorry to say, the next pandemic or any other kind of incidents and outbreaks. We've had the annual revision sign-off of the Northumberland Incident Response Plan, absolutely crucial, for, I think, for all of the flooding and other kind of severe weather issues that we've seen over recent, particularly I think it's recent 18 months really, isn't it? But certainly seeing more frequently. And they have developed a competency framework and training for the directors and executive directors. And I think we have a really robust kind of governance arrangements there as well. But also just looking at some of that data for people who are in vulnerable households and make sure we have really quick and early access to the data on who's most vulnerable. We've seen the development of Northumberland Air Quality Strategy that I believe is going to Cabinet or has just gone to Cabinet next week. So I mean, absolutely crucial in terms of indoor and outdoor air quality, but it's not just about, although it's good in Northumberland compared to other areas, it's incumbent on us to make sure we keep it that way, and that actually we're ensuring we maintain really good air strategy and also look at some of those inequalities and look at some of those pockets. So that's been a really fantastic piece of work led by our public protection team with public health involvement, the climate change team and others. So again, a really fantastic piece of work. And then as part of one of the themed meetings we had around screening, cancer and non-cancer screening, one of the outputs was to develop a screening inequalities subgroup that is meeting regularly. And we've already seen a lot of benefits in terms of just linking up the providers with with training opportunities in general practice, but also with some of our community groups as well, so that they can work on some of that engagement around screening and promote uptake, particularly in those groups who have lower uptake. So in terms of some of those key issues, I thought rather than go through all the data, you don't want that probably today. You've got the pack if you want to have a look and you can ask. I thought we'd just kind of cover some of what have been some of the issues of the past 12 months and into this season that we're looking at. We talked about the increase in cases starting in the West Midlands, spread fairly rapidly to London, which is where we saw a big increase in the number of measles cases. It spread nationally, but I'm pleased to say we have had a large outbreak in Teesside in the summer. I'm pleased to say that actually there hasn't been any ongoing community transmission in recent months. I'm hoping, looking at John, hoping that's still the case, but you can correct us by all means. And there has been an MMR catch-up campaign within general practices as well, and also supported by the school-age immunisation team. So we haven't yet had, I'm pleased to say, any cases in Northumberland. That's not the case, I'm afraid, for pertussis or whooping cough, which, I mean, we do see cases, and you do see sort of spikes every 3 to 5 years. It's not the most effective vaccine in terms of it. Well, it's effective, but it's not as long-lasting as some others. So you do see sort of upticks in whooping cough, but equally we have seen just general declines in childhood vaccination. So really important that we get that message around childhood, but also pregnancy vaccination, because it's the vaccine in pregnancy that protects the babies when they're born, and we have seen an increase across all areas in Northumberland and across the northeast. Mpox is something we saw a little bit towards the end of the COVID pandemic. That was a slightly different kind of subspecies or sort of Mpox that we saw. Clade 2. We are seeing an upsurge in a number of African countries of a separate, what we call Clade 1b, and we've seen a number of cases in returning travellers and their household contacts in the UK and in some other countries as well. So that's something that we're keeping, a close eye, but it's considered actually, low risk at present by AXA to the public's health. Now, seasonal influenza is probably the biggest kind of thing you've been seeing in the news more recently in terms of its impact on hospital admissions and ambulances. So we're seeing it circulating now at high levels. It's been increasing week on week. We're seeing increasing GP consultations and hospitalisations and a number of care home outbreaks of flu over recent weeks as well, and a lot of support from our AXA team, health protection team, infection prevention control into some of those care homes. So that's, and then I'll talk about vaccination in a moment. Just before that, I just want to talk very briefly about avian influenza, so that you might know as bird flu. We have seen a number of cases, a small number of cases this 12 months. In this past 12 months, no commercial flocks. I think we did see 1 or 2 in 2023. But of H5N1 initially, and then a few more recently of H5N5. There is a current outbreak in East Yorkshire and Humber and sort of eastern England, which has affected a number of commercial poultry farms, and there are isolation zones. So that's, I think, been kept under close observation. I think still the assessment is that there's currently a low risk to the public's health from avian influenza. There have been, you'll have seen in the United States, a number of cross-species cases, so into some of the dairy herds, and then some of the dairy herd workers who have had symptoms. It has tended to be mild symptoms, I'm pleased to say, and I think, obviously the AXA are very vigilant, and amongst others, and WHO around any transmission that makes it more likely that it would be person-to-person transmission. So I just wanted to briefly talk about this season's flu and COVID vaccination. I think we still, there are still numbers coming in, so I don't want to be giving you the kind of final numbers because they may well change. But I can give you just a bit of a flavour for where we are, and I think both the achievements, but also the challenges or opportunities that we have as well. Just a reminder, it's the ICB and NHS England who have kind of responsibility for different parts of the commission and coordinating a lot of the delivery in general practice, primary care networks and pharmacies and others around flu and COVID vaccination. I'm pleased to say Northumberland has had better uptake this autumn-winter than either the region or England, which is fairly typical, and that's across all of our at-risk groups for flu and for COVID. We've actually seen it improve for flu this year compared to last year, but not so much for COVID. So that's been probably more of a challenge. Flu vaccination uptake for pregnant women is considerably better here, and I think that's a testament to the work of the maternity services team. So, but it's still not great, but almost around half of women will have the flu vaccine in Northumberland compared to about a third nationally. So still a challenge. And really, apart from those people over 65, it's still below that 75% target that we'd like to achieve. And it's those inequalities which are, I suppose, some of that concern, inequalities by level of deprivation, but also by ethnicity and that geographical variation. So I think a huge amount of work that's done by general practice colleagues, by pharmacies, by Northumbria team who have been supporting some of the housebound as well. But actually, it's always going to be a challenge each year. And I think one of the focuses for this coming year will definitely be in how we can work as a system through this local immunisation steering group to be able to maximise uptake, but it will also address some of those inequalities. So this is the last kind of last couple of slides of content. You'll be pleased to hear, Graham. I think first, as I say, I think the key development plan for the next year is around vaccination inequalities. We'll be setting up a vaccine inequalities subgroup as we have for screening. That will particularly focus on, I think, matching that engagement with communities with what can be delivered, by general practice and others in terms of vaccination. And there's a small pot of funding for childhood vaccination, working with Harrogate and amongst others about how we can best use that to help address childhood vaccination inequalities. And I think one of the key things we move into 5 years since the start of the pandemic is about, from a local authority perspective in particular, make sure that we've got a really robust pandemic plan. We do have a plan, but it's about refreshing that and make sure that that's fit for purpose. So there's work ongoing now, and that's going to be a key focus, I think, for spring, for myself and for Helen, but also involving many of others across the system. We'll do some work regionally to bring together some of that learning and what we need to cover in those plans, and then bring that back to local authority, a number of workshops. And that's in preparation for Exercise Pegasus, which is a national pandemic exercise that will be in autumn, to make sure we have really robust arrangements in place for that. So my recommendation to the Health and Wellbeing Board is to just really invite you to note and comment on the kind of wide range of multi-agency activity of the Health Protection Assurance and Development Partnership. But thank you for your time today.
Thank you very much, Jim. Open to the floor. Wendy.
Thank you, Chair. Jim, just wondering, why is the RSV vaccination for respiratory infections only 75 to 79? What's the reason for the cut-off?
I'd have to just go back into some of the detail, which I can let you know, but my assumption would be that it would be an assessment of the risks and the benefits in terms of population, and it's particularly going to be around the health economic benefits and risk in terms of making sure that any vaccination program is a good use of taxpayers' money. And actually the highest risk is going to be in that kind of age group in terms of admissions, typically with RSV infections into hospital, in terms of and where the greatest harms will be, but also in terms of those young children, it's particularly premature infants. I remember from my GP and paediatrics days, that was particularly the group you would see. So it's really important that it was that pregnant women get the RSV vaccination as well. So it was, it's one of those things you can, with any screening program, with any vaccination program, you need to make sure that you have that it's a cost-effective use of funding, and it's not because there's always going to be limited funding, but also limited capacity to deliver the program as well.
I think the sad fact is, and it overlaps with the economics, it doesn't work particularly well in the very old. So actually it comes back to it's not effective. So it's not, they could clearly benefit if the vaccine worked for them. It doesn't particularly work when you get over 80 and older. So that's why the window's there. So it's about the vaccines dropping off in effectiveness, which then means it's no longer cost effective. If it did work, that population would clearly be really key to get it, but it just doesn't work as you get older, unfortunately.
Thank you. Thank you.
Thank you, everyone. One of the things caught my eye was just a comment was we seem to be very good at the cancer screening and the screening, but I didn't really understand why we don't do so well on the AAA screening. And there was a question in my mind that I'd be grateful to pick up with you at some point on that, please.
I don't have the answer, but that's an area we do need to just have a look at. And then also we don't have the data on the diabetic eye screening that we're seeking to get as well. And that'll be a little bit of a focus, in the next 12 months as well.
Jill?
Yeah, I just feel obliged because my job title is referenced numerous times in the report, and I do have that statutory responsibility, but I really want to acknowledge in this forum the implementation from John and the continuation from yourself, Jim, because this is something that we didn't have. There was really robust governance during COVID, but not an overarching health protection board. So a lot of work went with partners to co-create what we've now got, which is a really strong relationship piece, because as you said, it's about creating the relationships at peacetime, so that if we do end up in any kind of incident scenario where we are back in pandemic situation, we've already got those relationships and the policies and practice in place. So thank you.
John?
Just kind of back on that, Jill, and I think, as you said, it is about those kind of arrangements and partnership working in peacetime, and it's not to say that pandemic
Okay, so thank you for a very comprehensive report. Can we all agree on accepting the report and the recommendations that are with it? Thank you very much. So I'll move us on to the final main agenda item, which is item number 6, the Northumberland Tobacco Control Partnership Annual Update 2024. It's 2025 now, by the way. Wendy or Veronica, who's introducing this, or both perhaps?
Thank you very much, and good morning, everyone. I think, in a way, we have something to celebrate here. I think it's 25 years since we started our Stop Smoking service, so it's an anniversary year for us. And I think, well, I've got to say it's a privilege for me because I chair the Tobacco Control Group, and I have to tell you that the members, including Kerry and obviously Nicola, who helps her, I have to say that it is a marvellous group of people and they're extremely dedicated into stopping smoking in Northumberland. And just an interesting point before I hand over to Kerry, I'm just reading here that it's really only 75 years since Professor Richard Doll made the connection between smoking and lung cancer and published that in the British Medical Journal. So we have come an enormous way in 75 years when you think we've been smoking for centuries in this country. And we've come an enormous way because Northumberland is doing really well. And I'm going to hand over to Kerry, who will now tell you all about it.
Continuing to keep this as a priority and inviting myself on behalf of the Tobacco Partnership to come and present annually. I was told to keep it brief, so I'll try and keep it brief as much as I can and stick to 10 minutes, but we'll see how it goes and we'll see how the Chair indulges us on me. So I'll just very quickly kind of take you through some of the headings in the content of the paper, but I can't go into it in detail. It's always a delightful annual challenge for me to try and summarise the work of everything that we're doing in Northumberland in relation to tobacco, but also give a little bit of credit and justice to all of the partners that also work on it. Like I say, it's a delightful challenge. I can't cover it all, so hopefully the paper will do its own talking, and you've seen it, and you could be able to raise any questions. Firstly, obviously, it links with the corporate and the system-wide priority that we have, which is to reduce health inequalities. And what we've tried to do this time, that's not me, is take that theme that Wendy's just introduced. We're very, very pleased and happy to be able to celebrate 25 years of the Northumberland Stop Smoking service. So the group decided to let's do that. Let's have a little historical lean back into the progress that has been made in tobacco, and particularly in Northumberland as well. But what I wanted to do for this paper and for yourselves is to use that lean back to bring us further forward. We've got another 5, 10, 15 years of concerted effort to make. Now is not the time to stop, and hopefully the paper and a couple of things that I'll highlight this morning will demonstrate why we need to really keep going. So the content of the paper is on the right-hand side. I could talk for 20 minutes about each one of those, as well, some of you know. So I apologise if I can't touch on it, but please do ask any questions today. But also, this is ongoing. We actually have a tobacco partnership meeting at the end of January. So if anything occurs to you after today, if you channel that through Councillor Patterson, Jill, Chair, it will find its way to me, and we will address it in the next partnership meeting. So, I'm still going to say the same things that I say annually, and I will continue to say them kind of until it's no longer the case. Smoking remains the biggest preventable cause of death and illness in Northumberland. It is the leading driver of local health inequalities. The greatest harms fall on our poorest and most vulnerable individuals and communities. And hopefully what you'll be able to do as well from reading the paper and just thinking about it for 10 minutes is to start to draw those links. I know he's walking out of the room, but between the presentation that Dr. Blair has given, the presentation that Jim has given, you can see that the work that we're doing in the Tobacco Partnership helps with all of that. Like we said, we've had a stop smoking service here for 25 years. When we started that, prevalence in our county was up to 30%. So even just in my career, that short career that's passed in a flash, we've seen that prevalence come down to 8.2%. The graph shows it there. It means that we are tantalisingly close to the vision that the partnership put together and we presented to you when we first started the partnership, which was to achieve a 5% smoking rate, or less obviously, in Northumberland by 2030. There's some modelling done by University College of London on the regional footprint. I know people are asking about the North East footprint. We've got lots of data on that. That if the North East was to reach that 5%, there's some ifs and ands that are in there, quite challenging ones, but actually if we achieved that same kind of modelled trajectory, we would get there in Northumberland, which is really exciting. But I would highlight a couple of those stats on there. If we are to use that modelling, if we are to get to 5%, we would be expecting 46% of smokers to make a quit attempt. Nearly half of all smokers to make some sort of quit attempt, and that's challenging. With 29% of them being successful, which actually is the less challenging bit. It's the making the quit attempt that's the thing that we really need to focus on. It is ambitious. And I wanted to say then, to put this back into the wider context, it's a population issue. It's a system-wide issue. We will never see all of those people in Nicola and Mark's stop smoking service or in the trust service, or in the public health service for 0 to 19s. We won't see them there. These are people who will just be making their own decisions to quit smoking and do it in a number of different ways. So it's really important that we continue with this partnership work. It's only if we continue to look at tobacco's position in society, so working with trading standards, which I don't really focus on this year in this paper, but we have talked about it recently. So the focus on access, availability, the profile of tobacco in our society, we need to disrupt all of that, so that people can actually make the choice to quit smoking, know that there's services to help them, or to actually decide never to start to smoke in the first place. The other thing about the modelling, which is important to say, that as prevalence declines, the people that are still smoking are doing so for a variety of complex reasons. It goes beyond choice. And again, in the public health team, it'll probably be Jim you'll be hearing from in the future, but we're starting to really look at tobacco as the sort of original blueprint of this, of kind of how people are influenced, how their health is determined by things that isn't just about personal individual choice. And we're looking at that around commercial determinants. So tobacco is a good example, but I'm sure there'll be a future time we'll be able to talk about alcohol, which has come up today, food, gambling, that sort of thing. But certainly the approach that we're taking in the partnership sets a blueprint for that. Because smoking rates don't come down on their own. This isn't in the paper, but it's a really good example of showing that. We have to keep doing all of the things that we do at a national and a policy and a legislative level, as well as all of the local work, in order to keep it going. Because if for whatever reason it's a slower year for that kind of thing, the risk is that those smoking prevalence rates start to plateau and at worst can actually start to increase. So we have to keep going. So that's why I mentioned in the paper the tobacco and vapes bill. That's our latest thing. That's the thing that we must all endorse and support at the moment. If we can do that, obviously it's going to help with this kind of ongoing legislative and policy level work which oversees, underpins all of the work that we do locally. So I did indulge myself in a historical look back, thoroughly enjoyed myself going down this rabbit hole. There's actually on the next slide, we've already mentioned the 1954 BMJ article when Richard Doll first published findings showing that smoking and lung cancer were linked. Less than a decade later, the Royal College of Physicians took that research and made a strong epidemiological case for the harm that was done by smoking to, for a range of different diseases and conditions. What's really interesting is it called on government then, 60 plus years ago, to implement a raft of public health measures to reduce smoking, to advise patients to quit, to help them to do that. There is a link on that. I don't think we've got time, unless we have got time, and if we have, we can play it. But there's a link on there when you get the slides. Do click on it. It's from the BBC archive from when that report was released in 1962. And you can see how our society has changed, how we look has changed, how we even speak has changed. What I was really struck by was that the interviewer himself said he was a smoker. Probably at that time there will have been about 70+% of the population were smokers then. The paper talks about life expectancy up to the age of 65, so that he went out onto the streets of London, talked to people about, about their smoking, and the aspiration was to live to 65. Now, we have a longer aspiration than that. 65 is not old anymore. And, just thinking about Alistair's sort of data this morning, we're looking beyond that. We're looking at 85 as where we want to get to. So that was really different, and we've come a long way in those 60 years. But what was quite similar is some of the people that were interviewed on the street sort of saying, this is out of my hands. No, this is not going to make any difference to me. I believe it, but it's out of my hands. It's not. It's in the hands of God or whatever. So really kind of interesting and current feelings about it. And also in this report 60 years ago, it said even one cigarette is doing you damage, and we still use that message now. So do click on it and say go down the rabbit hole like I did, but it's quite enjoyable to see. Compare it as well, and I've shown it to this board before and recently to elected members. Compare it to the interviews that were done recently in Ashington and Blyth on the streets and the beach, where particularly the smokers in the current sort of public don't want smoking to be a thing anymore, and they don't want it for themselves, they don't want it for their children or their grandchildren. So in the paper I have obviously focused on children and making that smoke-free generation, say indulge in the look back, but let's actually focus back in now on making that smoke-free generation. You have to be careful with the stats, and obviously we can help with any of that if you want to use any of this in reports or any committees. The top one again shows 40 years of action that have helped to reduce youth smoking. This is 11 to 15-year-olds, but the top graph is where the question is, have you ever smoked? So if you'd ever smoked what, you would tick yes to that. So the percentage is slightly higher. It's 11% of 11 to 15-year-olds now who have ever smoked, but the one below is the 11 to 15-year-olds who class themselves as a current smoker, and that's down to 3%. So all the graphs are going, I hope you've seen, they're all going in the right direction, and we've made really, it's only 60 years. It doesn't feel like that long, and certainly only 25 for a stop smoking service. So it's all going in the right direction. The other section that is in the paper, again, have a look, and we can provide more information on this as we receive it and as we learn it, is that as the youth smoking rates are coming down, we are obviously seeing vaping rates going up. Not to the same degree, and it's a slightly different issue, but we certainly are aware of it, and I wanted to draw attention for the board to some of the work and the thinking that we're doing on that now. So let's bring us right back up to date. Some highlights that I've given in the paper from 2024, focusing particularly on children, but a little bit on the Stop Smoking Service because we've had that look back. All of these are just examples, like I say, I can't talk about everybody, but certainly all of the partners that are highlighted in the paper are very active in the partnership. Sorted have been involved in the overall partnership, but also in a subgroup that we've set up to look at children and vaping. And in some work that they did early in 2024, out of 120 open cases of the children that they were seeing for substance misuse, 85%. I forgot. It's in the paper. It's a high proportion of those children that are using a substance are also using nicotine, and the problem is sometimes they're using it through a vape. So on the other side, and what I've given in the paper is some examples of what we're going to try to do about that. So Sorted are going to work with us very closely to set up a particular nicotine service with the new Stop Smoking grant that we have. Now, we have to make sure that children who are smoking tobacco are included in that piece of work, but obviously if they're using vapes as well, they'll be included. The Growing Healthy 0 to 19, the Public Health Service, now we've got representation here today, very active member of the Tobacco Partnership. Janelle has helped us a lot with understanding what you see in that service and the support that families need. And particularly, it's a really good example of why the partnership has worked, because Janelle invited Trading Standards to come and update the workforce, talk to them about the importance of, if they hear anything from families about illicit an illegal product, to let Trading Standards know, because they need that intelligence to act on. So they're doing that actively now. Best Start in Life pathway from Northumbria Healthcare. All pregnant women are entered onto that Best Start in Life pathway at booking and are supported through till 28 days post-delivery. And the Trust is seeing some really fantastic results now with pregnant women and quitting smoking. And then I've also highlighted some examples from the Stop Smoking service. We've had a particular focus on people with severe mental illness and continue to do so. And obviously we've also engaged in the National Swap to Stop programme. So on the right-hand side, we'll continue and we'll do more of that. All of it underpinned by some regional work around insights to make sure that we're still saying the right things and doing the right things. I think Nicola would agree as kind of the lead for the partnership, and with Wendy's support, we do need to still get better at that, at understanding what communities are saying and what they can do themselves and what they need us to help them with. So I think that would also be a focus going into 2025. Oh, has it moved? Okay, so that's it. Summary and options for the board. Just as I've said, if we are to achieve this collective ambition that we have for a smoke-free society, I say we are tantalisingly close to it, but we've still got hundreds, thousands of smokers in Northumberland, and if we're going to achieve that 5% or less, if we're going to create a generation for our children who will never smoke, we need to keep going. And the next 5 years, the next 10 years are really important. What I ask the board is obviously to note the development and the hard work of all the partners in the partnership and the progression and the celebration that we've got going this year, but also to particularly ask for you to grant authorisation to your representatives to continue to be a part of that partnership and to keep this as high profile as we have been able to thus far. Thank you.
Thank you very much. It's always a pleasure to hear you speak about your topic, because you're so enthusiastic about it, and I think that's one of the reasons why you've achieved so much. So thank you, Kerry. I also wanted to let us play the thing. We are behind time, and I know how hard it is to embed something in a slide. So please, would you go and look at Kerry's little video for me? That would be excellent. Thank you. Have we got any comments or questions from the floor, please? Abby?
I mean, echo your comments, Chair. It is an amazing achievement to have got to where we are, and also compared to some of the stats earlier, to be so much better than other parts of England as well is hugely important. I do really also commend you for the introduction of the vape bin conversation, because I remember when we had this conversation a year ago, it wasn't there. And you know, if we're going to, smoke-free is an interesting term, because as a parent of three, and there's a very, very distinct difference between my 16-year-old and my 14-year-old. there is a huge amount of the 11, and you can see that in the national statistics, in terms of 11 to 15-year-olds, you've now got 25% of them have tried vapes, 10% of them are consistent smokers. They are smokers. They're not smoking tobacco, but they're taking nicotine. And I think there needs to be a push around the drug of nicotine rather than the effect of tobacco and smoke, because I'm aware of children not just using vapes as a vehicle to smoke marijuana and spice, but also taking nicotine replacement products like chewing gum and having patches as a way to get high. And I just wonder how we can wrap that up, because it's so, you're right, Graham, your enthusiasm is amazing, and actually your dedication and your drive is what's going to make that difference. But I'm just really keen to make sure that's involved in that. If that's possible?
Yeah, I'm really excited, Abby, with the work that we've done with the grant so far to get things ready to launch. And I believe it's launched. 1st of January is the work that's sorted. They came to us and we came to them. It really is a good example of the two partners coming together to say we want to do something together about this. So with the grant that came to local authorities for Stop Smoking, we are going to, are going to deliver a nicotine-focused support person. There's a person who's going to lead it, but obviously we're keen to kind of see how it can be embedded across the whole of Sorted, because I think that's the right place, and it's always been a bit of a gap. The Stop Smoking service will see young people, but young people don't access that Stop Smoking service, and there are reasons, and very good ones, why that is. And Sorted were never quite specifically commissioned for this. It was more for the drugs and alcohol. So this is, it's taken a while. We have been talking about this for a long time, but we've got there, and it's really exciting. And Sorted are really excited to kind of to start to help young people who are vaping. So the thing is with it being placed there is, yes, it'll be children who are smoking tobacco. It'll be children who are using nicotine vapes, but it will be the children that are using the vapes for other substances as well. Yeah. So next year we'll talk about how that's been going.
And what an awesome way as well, this whole board is about cross-party working and system working, and actually what you just articulated was two partners and local partners coming together to do something different.
Thank you very much. So, thanks to you and your team.
Thank you.
We accept the paper and agree with the recommendations. Thank you. Okay.
Thank you.
So that brings us on to item 7, the forward plan, which is there for information. I would draw your eyes to February, and if it looks like an organisation is there to do something, have a think about it. I'm sure Jill will be in touch, or Andrea will be in touch to get things in place. I also had a look at the list of the things that we've actually done. And I think actually it's a really useful thing at times just to look back at the list of the papers that have been through health and well-being. You kind of start to realise how much things we do think about and talk about. But also I think sometimes when I come to these meetings, I deal with the present and I do one or two things with it at the time and have some ideas and go away. But it's also useful to look back at it and think, well, what did that conversation lead to? And did I follow up where I thought I should have done? And actually it reinforces a little bit as well. So if you have got some time, have a look at that list, and if you can access any of those papers that you need to, I'm sure historically they're there on the website. Yeah. I think it's a useful exercise at times, because I think reflection is good if we've got the time, and life can be very busy and we don't always do it. So that's the forward plan. We don't have any urgent business today. So the date of the next meeting is the 13th of February at 10 a.m. Thank you very much.